Hello students, we are going to study shock. Shock is also known as circulatory collapse. It is characterized by systemic hypotension either due to reduced cardiac output or due to reduced effective circulatory blood volume. Consequences of shock are impaired tissue perfusion and cellular hypoxia. So due to perfusion deficient, there is insufficient delivery of oxygen and nutrients to the cells and inadequate clearance of metabolites that will lead to shifting of aerobic to anaerobic metabolism, which will cause lactic acid production leading to lactic acidosis. So initially the hemodynamic and metabolic derangements, they are correctable and induce reversible injury to cells. But if it persists, shock state persists, it will lead to irreversible injury and death of the cells. Types of shock. There are three major types of shocks: cardiogenic shock, hypovolemic shock and septic shock. Other types are neurogenic shock, that is due to anesthetic accidents or spinal cord injury, and anaphylactic shock, that is due to drug and pollen. First of all, we are discussing cardiogenic shock. Cardiogenic shock, it results from low cardiac output from acute disease of heart, which may be due to deficient emptying in case of myocardial infarction and cardiac arrhythmias, due to deficient filling of heart, due to cardiac tamponade, or due to obstruction to outflow because of pulmonary embolism. Second is hypovolemic shock, also known as traumatic shock or hemorrhagic shock. There is reduction in blood volume that will induce hypovolemic shock leading to low cardiac output. Causes of hypovolemic shock are severe hemorrhage, external or internal hemorrhage. Example, in case of trauma and surgery when there is loss of blood. If fluid loss occur, example in severe burns, severe vomiting, severe diarrhea causing dehydration, then patient may lead into hypovolemic shock. Septic shock. Septic shock is the most common cause of death in ICUs. It results from spread of microbes from the localized infections like abscess, pneumonia, peritonitis into the bloodstream. Causes of septic shock. Septic shock is most frequently caused by gram-positive bacterial infection, followed by gram-negative bacteria and fungal infections. Now, the predisposing conditions for septic shock are chemotherapy that will lead to immunosuppression, HIV infection, invasive procedures, advanced age, prevalence of multi-drug resistant organisms in hospital, and super antigens. Major pathogenic pathway in septic shock is microbial products that will activate the endothelial cells, cellular and humoral elements of immune system, that will further initiate a cascade of events leading to end-stage multi-organ failure. So in septic shock, lipopolysaccharide is the causative endotoxin. The cytokine storm of TNF, interleukin 1, interleukin 6 in response to the bacterial antigens, lipopolysaccharides from gram-negative bacilli, that will result in systemic vasodilatation, reduced cardiac contractility, widespread endothelial injury and its activation, and systemic activation of coagulation cascade leading to DIC. So the lipopolysaccharide that act as endotoxin, it will release the cytokines, tissue necrotic factors, interleukin 1, interleukin 6, interleukin 8, that will further releases nitric oxide, platelet activating factors and other mediators that will further lead to either endothelial cell activation or activation of the macrophages, neutrophils, and complement pathway activation, leading to local inflammation. If the mediators are in moderate quantities, they will lead to systemic effects like fever, release of acute phase reactants. If these components are in high quantity, then it will affect the heart by reducing the cardiac contractility, leading to low cardiac output, low peripheral resistance of the blood vessels, and injury to blood vessel leading to thrombosis and DIC, acute respiratory distress syndrome, and septic shock. This is also a flow chart showing the pathogenesis of septic shock. The endotoxin and other microbial products released by the bacteria that will cause complement activation, leading to endothelial activation, or activate the neutrophil and monocyte that will further activate the endothelial cells. This activation of endothelial cells and release of cytokines, cytokine-like mediator, that will cause increase in procoagulant factors, decrease in antifibrinolytic factors, release of other cytokines and reactive oxygen species, leading to vasodilatation, increased permeability of the vessels, decreased perfusion, and lead to multi-organ failure. Procoagulant activity is increased and decrease in antifibrinolytic activity that will cause microvascular thrombosis or disseminated intravascular coagulation that will lead to tissue ischemia and will cause adrenal insufficiency and multi-organ failure. Due to release of cytokines, systemic effects like fever, metabolic abnormalities, diminished myocardial contractility will occur that will further lead to multi-organ failure. The release of interleukin 10, apoptosis, and soluble TNF receptor, these are the secondary anti-inflammatory mediators that will lead to immunosuppression. Now, stages of shock. First stage is non-progressive stage, then progressive stage, and last is irreversible stage. In non-progressive stage, reflex compensatory mechanisms are activated and perfusion of vital organ is maintained. It is a variety of neurohumoral mechanisms that help to maintain the cardiac output and renal pressure, including renin-angiotensin system that will cause renal conservation of fluid, that will help in renal conservation of fluid. Baroreceptor reflexes, they will release catecholamines to maintain the blood pressure. ADH further retains water and maintain the blood volume. There is generalized sympathetic stimulation that will cause cutaneous vasoconstriction to maintain blood supply to vital organs. Cold and pale skin characteristic manifestation of shock is due to sympathetic stimulation. If causes are not corrected in non-progressive stage, it will lead to progressive stage. There is widespread tissue hypoxia due to failure of non-progressive stage to maintain blood supply to vital organs. Anaerobic glycolysis replaces the aerobic respiration due to hypoxia, leading to lactic acidosis. There is pooling of blood in microcirculation due to arteriolar dilatation in response to low tissue pH. There is fall in cardiac output. DIC will occur due to anoxic injury to the endothelial cells. There is multi-organ failure due to tissue hypoxia. There is decreased urine output and patient is in state of confusion. Last stage is irreversible stage. In irreversible stage, lysosomal enzyme leakage occur due to anoxic cell injury that will further aggravate the shock stage. There is worsening of myocardial contractility due to nitric oxide release. Endotoxin shock may supervene if intestinal flora from ischemic bowel enter the circulation. There is complete renal shutdown due to acute tubular necrosis, and in spite of all effort, patient condition worsens and death may follow. Now, the morphological changes in shock, essentially ischemic involving multiple organs. The morphological changes are due to ischemia. First, heart. Heart shows subendocardial hemorrhage and patchy myocardial necrosis. Brain shows areas of hemorrhage. In kidney, there is acute tubular necrosis. Though lungs are seldom affected in pure hypovolemic shock because they are somewhat resistant to hypoxic injury. However, when shock is caused by bacterial sepsis or trauma, that will lead to diffuse alveolar damage, also known as shock lung. There may be interstitial pneumonitis and edema. Adrenal glands, they show hemorrhage in inner cortex, and there is cortical cell lipid depletion. GIT, there is acute stress ulcer. In septic shock, when there is development of DIC, it will lead to widespread deposition of fibrin-rich microthrombi in brain, heart, lung, kidney, adrenal glands, and GI tract. Due to consumption of platelets and coagulation factors, there often appearance of petechial hemorrhages on serosal surface and on skin. Clinical picture in shock. First stage of shock. In case of hypovolemic and cardiogenic shock, patient has weak and rapid pulse, cool skin, cyanotic skin, there is tachypnea. In case of septic shock, initially warm and hyperemic. Patient is warm and hyperemic due to vasodilatation. Then there is electrolyte disturbances and metabolic acidosis. In second stage of shock, patient has renal insufficiency and renal failure, electrolyte imbalance, coagulopathy, and disseminated intravascular coagulation. Now coming to prognosis. Hypovolemic shock has better prognosis. If patient is young and healthy, 90% survive with proper management. While the cardiogenic and septic shock, they have poor prognosis. That's all in shock. Thank you.